I'm Eli Stokels in Washington. I'm joined by Dr. Patrick Soon-Shiong, the executive chairman of the Los Angeles Times. Dr. Soon-Shiong is a surgeon and scientist who has spent his career studying the immune system in order to fight cancer and infectious disease. He is also the chairman and CEO of the biotech company NantWorks and the owner or investor in other companies researching treatments for COVID-19. Tonight, in our 8th episode of this series, as the third wave of the coronavirus spreads across the country, we look at what's happening on college campuses. Students will be traveling home for Thanksgiving just as the nation is recording over 100,000 cases a day. Without widespread testing on campuses, public health officials are worried about students becoming so-called secret spreaders once they leave school. And there is reason to worry. Since the spring, 250,000 infections and a few deaths have been reported at 1,600 colleges, according to data collected by the New York Times. Without a national plan to manage the virus, colleges and universities have written their own rules. The result, as you might expect, is a patchwork of protocols that vary widely. Listen to what a few students told us.
Hi, I'm a sophomore at the University of Hawaii at Manoa. We're only tested if we report to the campus clinic or the Lumicide app with COVID symptoms. If we test positive, then we have to quarantine at a hotel for 2 weeks.
Hi, I'm a freshman at Tulane University, and we used to get tested twice a week, but now we get tested 3 times a week.
The University of Texas doesn't require weekly COVID tests, but they really encourage us to get tested as much as possible, and they make it super easy for us to get tested.
I go to UC Berkeley, and we get tested twice a week.
I am a second-year student at the University of Georgia. Here at UGA, we are doing coronavirus testing as needed, so students can go get tested before going home for a visit or coming back, or just going to get tested because they want to get tested.
Hi, I'm a freshman at Sarah Lawrence College. We're required to get tested every 2 weeks, and so far there have been no issues. We're actually about to get tested again in a couple days.
The last time I was tested was today. I went this morning. I usually go on Tuesdays and Fridays.
I've been tested about 8 times now, and the university is requiring tests when you go to football games. You have to show a negative test.
The last time I was tested was about 3 to 4 weeks ago.
And my next test is actually tomorrow.
I have not received a test since I've been back here, but I did do a test before I came to Hawaii.
Now, to be fair, there are many different kinds of tests available, and it's not just the frequency of testing that counts, but how accurate the test is as well. Still, though, the overall picture is that most schools are not screening all of their students on a regular basis, and that means they are missing the secret spreaders. Joining us now are Professor Chris Marsicano of Davidson College in North Carolina and Emily Rounds, a Davidson senior. Marsicano is founding director of the College Crisis Initiative, a research group analyzing COVID-19 protocols on campuses across the country. And Rounds is a researcher with that group. And I should note both are joining us from places other than Davidson, North Carolina, because both are working and teaching remotely this semester. Thank you both for being with us. Professor Marsicano, I'd like to start with you. You and your group have collected data on more than 1,400 colleges across the country. Can you tell us more about your research? Did what we just hear from the students in that piece track with what you found so far?
Absolutely. First, Eli, I want to thank you so much for the opportunity to join you on Second Opinion, and especially for the opportunity to showcase the work of students like Emily, who make and power the College Crisis Initiative at Davidson College. A patchwork is what you use to describe the different modes of instruction and testing plans across the country, and that's certainly what we see. Only about 45% of colleges and universities are fully online. We have around 21% that are hybrid or high flex, which have a mix of online or in-person instruction, and only 26% of colleges and universities are fully in person, with the rest doing something entirely. We have a very small number of institutions that are testing weekly that can find those secret spreaders. Only about 7.7% of our schools in our data set are testing weekly or twice weekly.
Are you able to speculate, Professor, on why exactly more schools aren't doing mandatory testing? I know a college is there to educate, but there usually are medical facilities on campus. Why haven't we seen a more robust response, do you think?
Frankly, it's extraordinarily expensive. each test costs about $100 per student per test. So what you end up having is on smaller institutions, places like Davidson, like Bowdoin or Colby, you can actually test everybody weekly. But those institutions that are very large, 30,000 students, like the University of Georgia or the University of Texas at Austin, like the students in the package, it's very, very difficult to make sure to test everybody simply because it is so cost prohibitive.
And that makes a lot of sense, especially given the financial difficulties a lot of colleges were having before the pandemic that have been only exacerbated by what's happened over the last year. Emily, as a student and a researcher, I want to ask you how important it is that students buy into not just the testing program, but also mask wearing, social distancing, all the other things that may feel inconvenient, not what you pictured in terms of a college experience. Why do you think it's so important for people in your position to adhere to those protocols?
I think that in order to have a successful COVID-19 plan at a college or university, it's essential not just to have a weekly testing plan or a robust testing plan, but social cohesion is a massive component. Students need to buy into supporting their community and recognizing that these efforts are not just to keep themselves safe, but also to keep their whole community safe. While college students, yes, do fairly well with the virus, there are also staff and faculty members who are higher risk. College students also have an impact on local communities, as Dr. Marsicano's research this semester showed, and they will then have an impact on their families when they go home for Thanksgiving.
As you just said, thousands of students will be heading home soon for the holidays as infections are rising in nearly every state across the country. Emily, have you found that colleges are taking steps now to screen students before sending them home?
Limited institutions, yes. We have actually been tracking this over the last 3 days out of curiosity and also to see if there are any patterns within the institutions. I ran a sample of approximately 100 institutions from our sample of 1,400, and I found that in approximately 100 institutions, only 8 had COVID-19 exit plans. And that said, there are some institutions that are doing weekly testing, but that is such a small percent that those institutions really, while they are keeping their smaller institutions safe, we have to look out for large public institutions that are not doing exit testing and that are not mandating it. While it's great that these institutions such as UT Austin and such as Purdue are encouraging testing, it's not mandated, just because I understand that it's so difficult to mandate tens of thousands of students to get COVID tested and to control that. But I think we will see the repercussions in hometowns and also in nuclear families when students go home.
Professor Marsicano, you've told us that what you've learned has been keeping you up at night, and that's easy to understand. I mean, there's Emily and students who obviously are very aware of what they have to do here, but it just seems like with college students in general, the inclination is maybe to just believe that you're invincible, that you don't need to take these precautions or to maybe get tired of wearing a mask after several months of it. Can you talk about why this is so unnerving to you, the more research that you've done?
Absolutely. And before I say anything about the research, I should note that so many students really do want to make it work. They don't want to be sitting in their parents' basement playing Xbox any more than their parents want them to be sitting in their parents' basement playing Xbox. But with respect to the research, we've seen clear research from Paul Niekamp and Dan Mangrum at the New York Fed and Ball State University, with my own research team led by Martin Anderson at UNC Greensboro and others at Indiana University and the University of Washington, that anytime students move from point A to point B, they provide the opportunity for COVID-19 to spread. We saw it at the beginning of the semester with colleges reopening for hybrid or in-person instruction. That's contributing around 3,000 cases per day as they opened to the total COVID-19 cases in the country. At that time, in late August, early September, that was around 7% of all COVID-19 cases in the country were due to college students. If institutions do not test their students, if they do not try to keep that student mobility down, keep them on campus, then the chances of them going off campus and spreading the disease and getting their grandmothers sick at Thanksgiving get incredibly high, much higher.
You know, we've talked throughout this series about the attention that has been paid to the ways that this pandemic has exposed inequalities in our society. Professor, have you found that dynamic playing out on college campuses as well? Are schools with more resources perhaps able to put together stronger testing programs?
Absolutely. Institutions across the country of a large amount of means, or institutions with large endowments relative to their student body, are able to pay for those $100 tests for students per week. They're able to continue to funnel resources to in-person instruction and doing in-person instruction safely. Institutions that may be less wealthy, institutions that are larger and deal with a large number of students, have had to transition online or have less robust testing plans on their campus. I want to give a shout out, though, to the Cal State institutions who made the decision very early on to go online and provide their students with a high quality online education by investing in training professors as to how to teach online. But even still, there are anecdotal stories of students in their cars, in parking lots on these campuses, trying to get the best Wi-Fi possible in order to do their coursework. It is these inequalities between the rich and poor that worry us as we see colleges and universities pivoting and changing in response to the changing situation on the ground with COVID-19.
We're going to be turning in just a moment to a discussion of some solutions. But before we say goodbye to you and to Emily, Professor, I wonder if both of you can offer anything that you've seen resembling a bright spot when it comes to improving testing and awareness on campus. Emily, do you want to start?
Of course, thank you. I would say that innovations are the greatest thing that we've seen come out of COVID-19. Higher education likes to move slowly and likes to move and change in small increments over time. However, we have seen great innovations come from this. We have seen innovations at college campuses, including wastewater testing. We have seen media sources such as NPR go out and interview college students, and such as you are doing now with this segment and interviewing college students, to have student voices be in the conversation of what the future of COVID-19 will be. We have also seen HBCUs in North Carolina have great innovations. They have been able to stay safe for the most part and keep their case count down, even without robust testing. They have limited the ways in which movement is happening on and off campus, and they have really played into the social cohesion. I also think that while it's really easy to get caught up in the media of all the parties that students are having and frustration towards administrations, we also have to look at where things are going well. What schools are really committed to their students financially and are able to provide those resources, and how are students helping the community? While those don't get portrayed as much as the negative elements, it is definitely good to look at because I think it shows what awesome leaders there are for the future.
Happy to spend some time on that here. Professor, any other bright spots that you've noticed?
I also want to mention that it's been incredible to watch students like Emily grow and change and become ever more resilient in this crisis. We cannot stress enough that for every student who goes out and parties, there are 10 students trying to make this work. There are 10 students working hard to make the world a better place, to stay on campus, to wear their mask, and to do their testing.
It's a really important message and an important conversation. We're going to, of course, keep an eye on how this plays out over the next few weeks and months. Professor Marsicano, Emily Rounds, thank you both so much for joining us, and best of luck.
Thank you.
Thank you, Eli. It's been a pleasure.
Thanks. Okay, Dr. Soon-Shiong, I'd like to turn to you now. We've heard during this episode about just how varied the testing regimes at colleges and universities are, and we've heard about the stakes as well. Fortunately, there are some success stories and reasons to believe that there are paths to improvement of this problem. And we're about to meet some guests of yours who can talk about that. Dr. Pat?
Thank you, Eli. And there's a lot of talk about vaccines, and just full disclosure, I'm in the phase 1 trial of developing a vaccine. But I think the talk about vaccines has really eclipsed the whole issue, which I think is really important, especially as college students are going to come home through Thanksgiving. And as you heard, the real concern now of these what is concerned as secret spreaders. But there's been real innovation in testing and real progress made in colleges, and the opportunity to figure out how to design widespread testing for tens of thousands of colleges. So today we have a story of how this was done at Cornell at upstate New York, which is one of the country's leading institutions. And joining me now today is Dr. Michael Kotlikoff, provost and professor of molecular physiology at Cornell University, and Dr. Michael Mina, a professor at Harvard School of Public Health. So Dr. Kotlikoff has really spent amazing innovation time developing a lab, and let me show our viewers how this was done at one of the country's leading research institutions.
My name is Mike Kotlikoff. I'm provost at Cornell University, and I'm a professor of molecular physiology at Cornell. We made a decision, I would say late March, early April, that we needed to do everything possible to put ourselves in a position to open the campus in a safe manner. One of the things that we determined was we would have to control our ability to test and build our own lab. And we were fortunate to be able to have a diagnostic lab. It turns out to be an animal health diagnostic lab on campus that does large-scale surveillance testing for animals and does virus testing and PCR. And we used the expertise of that lab, created a new lab, and built PCR testing to scale. We're doing between 35 and 40,000 tests a week. So something on the order of a total student population in the 18,000 range. Every student, so they're all tested twice a week. Zero transmission has occurred in the classroom because if a student tests positive and they are taking a class in person, we will test every student in that classroom and their faculty member immediately, and we know that none of those have been infected by that student. We do the same thing in the dorms. We'll test the entire floor. We've had zero transmission in dorms. I would say perhaps the most important thing that has allowed Cornell to be successful is the fact that we're testing asymptomatic individuals constantly. That's something we haven't done broadly across the country. Really what we're doing in most cases is testing people when they get symptoms and walk in the door after, in most cases, after they've spread the virus to many other people.
So first, Dr. Kotlikoff, your team remarkably converted an animal lab into a state-of-the-art testing facility in under 2 months, especially. Not only did you successfully do that, you innovated this concept within your students with regard to pooling of the test. So perhaps you could share with us how you accomplished that.
Sure, Patrick, and thank you very much for having me. We are conducting about 45,000 tests per week or samples per week. We're testing every undergraduate at Cornell twice a week. And as I do the calculation, Cornell, with a population of about 28,000 students, faculty, and staff, is contributing about 4% of the total tests done in New York State with a population of about 20 million. It gives you a sense of the scale of testing that is really required to block transmission. And that's one thing that we've been able to do. We've had a couple outbreaks. We had an outbreak in the beginning of the year. We're seeing little spikes in cases now, but the main thing we've been able to do is prevent that cycle of transmission. So prevent the exponential spread as one individual who's asymptomatic passes it on and on. And the key to that is testing everyone, is testing asymptomatics. One of the problems we've had nationally is that we're really testing individuals that are symptomatic. And if you do that, you're always behind because you've always tested somebody and identified them as positive, likely after they've transmitted to many other people. We've been able to block that cycle by testing, getting people into isolation, and testing all the local networks around that individual and getting those people into isolation or quarantine.
So you wrote, as I recall, an op-ed piece about some of the issues that were with regard to the federal authorities were more accommodating. We'd have more places that would have the kind of availability of testing. Do you want to comment about that? In other words, would it help Because clearly we need not just more testing, but the kind of quality testing that you've implemented.
Yes, it's a great point. I mean, one of the huge national advantages this country has is our biomedical research labs. We have a biomedical infrastructure that is is peerless around the world. We've basically let that system sit on the sidelines, and we haven't recruited those labs like the lab that we built, or the Broad Institute at MIT, which has scaled up and provided testing for local areas. In our testing, we've provided testing for local school systems, and we're now offering to other colleges and universities in the area. There are many research universities that are quite capable of innovating in this way, expanding their testing capability. We've just, as I say, not taken advantage of a major strength of this country. It's part of the fact that we haven't had a national strategy, and we haven't responded to this pandemic as a national emergency. We've really overlaid a regulatory system that's based on individual tests for an individual person, but not sort of a public health approach to the pandemic.
So what would you recommend to this next administration? Because you're absolutely right. I mean, I think not only creating a national strategy, but creating maybe a public-private partnership with organizations like yourself to create a sustainable, because it is expensive to maintain that infrastructure and do this test, as you've heard, $100 per test, and not many universities or organizations can afford that. What would you recommend then as a national strategy for this next administration coming in?
Well, I do think we have to, as a nation, test more. So that means recruiting, and of course, we're now seeing other tests come to the fore, antigen tests, point-of-care tests, which are quite important. But we do have the capability of rapidly expanding and innovating, pooling to a greater degree, and creating the kinds of systems. It's not just the test, it's also the ability to notify the public health system, to notify people, to recruit and educate people that they need to be tested, so get compliance for testing. My suggestion would be really to put a plan in place that initiates those labs, allows them to innovate, has a compensation mechanism, because that's the other part of this. Insurance won't pay for surveillance testing, it'll pay for an individual test. And then coordinate that with the public health services in states so that we can get rapid notification and rapid action in terms of isolating people and keeping them out of the transmission cycle.
Dr. Mina, if I can turn to you with regard to your approach, and you've taken the approach to test at Harvard and through the Broad Institute. You've tested over 415,000, so great scale. Could you maybe discuss with us and our viewers how you've gone about it in your large-scale testing process?
Sure. There's certainly two different types of tests that I've really been engaged with. One, like Dr. Kotlikoff, has been PCR, and then there's also rapid antigen testing and all these rapid tools, which we'll come back to. But at the Broad, what we did was back in February, when this virus was really just starting to take off, and the CDC was somewhat fumbling around trying to get the assay up and running, and there was some failures early on. We ultimately, at the Broad Institute, we decided that we needed to figure out a better way to get testing up and running. There was no way that the public health laboratories in this country could tackle this. Public health has been generally devalued and defunded, and has no regulatory real language or landscape around it to enable it to be advanced. And so early on, all of the testing, and to this day, has been through this medical lens. And so it's been through many universities like Cornell and like what we've done at the Broad to really scale testing up. In our case, what we did was we worked with the Broad Institute's genetics platform. They're famous for being extraordinarily efficient at sequencing many, many samples. And they've done this, they raced to build the human genome and sequence the human genome years ago. And so this was a perfect place to try to say, hey, we need to do something efficiently and at scale. Can you help? And the Broad Institute essentially, almost in 2 to 3 weeks, completely transformed their genetics platform into an extraordinarily high throughput and efficient PCR testing platform for COVID that has now really served not just Boston, but is now serving academic institutions in particular, as well as some towns throughout most of New England.
Dr. Mina, could you describe the test when you say it's an antigen test? Is it a PCR test or an antigen test? And what's the sensitivity of that test in terms of capturing the point of the viral load?
Sure. So everything I was just talking about there was actually another PCR-based platform for testing. There's a whole different approach that I've been talking about a lot over the last few months, which is an antigen test-based approach. And this is to take testing out of the central laboratories and put it into people's homes. We have tests. They look something like this. This is a rapid antigen test. It's essentially a paper strip. And this is a plastic piece that I'm holding, but inside is a paper strip. And this is an antigen test. And so you take a sample, you swab your nose, essentially put that swab into some buffer, looks like contact lens solution. And then you put the test, you put some of a few drops onto a paper strip. It works just like a pregnancy test. And so if you actually look at the test itself, it's just this little piece of paper here, very, very small. And these can be scaled. The nice thing is that these can be built millions and tens or 20s of millions a day in the United States if we wanted to. And we could get them into homes. Every home could have 20 of these little paper strip tests. And you ask the home to use a test twice every week. We could get these into half of the homes across America, or start in certain states. In a state like Massachusetts, we have 7 million people. We could build 500,000 of these every day, and that's enough for every home to use, for every other home to use a test every week. And that's the kind of testing that on a big population scale can actually serve to stop outbreaks from growing and cause them to start undergoing exponential decay instead of growth by severing transmission chains, much like vaccines lead to herd immunity. If you get enough of these tests out to the community, you can actually induce population-level herd effects that will stop spread.
So, as I understand it, and for our viewers who have difficulty understanding different even antigen test, PCR test, lateral diffusion flow test, the paper test that you just showed, I think from a pragmatic or practical perspective, unfortunately, there are different solutions to different questions. I think from a college perspective, the way Dr. Kotlikoff has been presenting is to find a way where you capture the virus in the nose at the earliest possible time before it's actually replicated enough to spread to the larger population. On the other hand, you would have this other opportunity with this cheaper, quicker, faster strip pregnancy test. But unfortunately, and you may agree or disagree with me, Dr. Mina, with regard to the sensitivity of that, by the time that test captures, it's pretty late in the game in terms of replication, and you may have actually missed the first 3, but on a population basis, 3 days, I mean. So how do you, you have to find a way to marry between these two, and maybe I'd ask the two of you to discuss that amongst yourselves. And Dr. Kotlikoff, maybe if you would like to react to those differences in these two tests and how the public should understand it, because a test is not just a test, and this is very difficult for the public to understand.
Sure. I would say that we have to think about sensitivity a little bit differently. If you have something like a point-of-care tests that Michael has described that you use constantly. So yes, it may be slightly less sensitive than a PCR test, but if you use that every 2 days, every 3 days, when the virus starts to replicate and expand in your body, you will convert to positive. There are also some advantages, as Michael has pointed out in other venues, to an antigen test like this, in that it may not be a false positive later on, or PCR may be positive late in infection when you're also no longer infection, where the antigen test may turn negative at that point. So each of these tests have different pluses and minuses. And I think that, if you think about the major problem here, which is really breaking the cycle of transmission, we can't afford to really ignore any advantage in this battle. We're really in a war. We're seeing really rapid growth throughout the country. We need to deploy every kind of test that we can, use them carefully and thoughtfully, but we can't make the perfect the enemy of the good.
Dr. Mina?
Yeah, I'd agree. And I would say that, like Dr. Kotlikoff said, we have very different uses for these tests. A PCR test that has to get shipped out and go to a lab necessarily can't serve, for example, to give you an immediate result to make sure that somebody, for example, when they're walking into a nursing home, is negative at that moment. And so there's going to be very, very different needs. And I think one of the things that we have really lost track of in this pandemic is that this is a public health problem. This is a war that is a public health war. And I would say generally the federal government at large has been unwilling to recognize and move into what I call wartime mode, to take this with the gravitas and the urgency that it truly is. And for example, create new pathways at the FDA that evaluate tests with public health in mind and not medicine. These are very, very different things.
I completely agree with that. I think you put it very well, as an outbreak and as a war, and quite literally every day matters. For us to lose 1,000 people a day, if we were to say we're having, 5 jumbo jets a day, you would have maybe a different reaction, but it's exactly what's happening. So I think the conversations between the two of you has really been helpful. I think the other thing that we heard from our guests in the beginning is the inequalities of the care. On the one hand, this PCR test, which is very sensitive, but $100. On the other hand, the $5 test or the antigen test may capture it maybe 24 hours later. How do you address, do you think, this inequalities? And maybe if you can just speak just for a second on that. On the one hand, we have the Harvard and the MITs and the Cornells, but then you have these smaller institutions and even high schools that need these kinds of help. Dr. Kotlikoff, any comments on that?
It is a great point, Patrick. The inequalities extend not just to testing, but to the ability to isolate and quarantine. If you're, living in a single room or a very small house, your ability to isolate yourself is quite limited. This is part of, as Michael said, a kind of attacking this as a population problem as opposed to a individual person-by-person problem. Without that sort of system in place that is a full public health approach to this, we're just attacking it piece by piece. We've at Cornell, we did what we had to do to assure the safety of our community. And now, in fact, we are the safest part of the community, and all the infections that we see really are coming in from outside into the community. It absolutely can be done, but we've been forced into a mode of doing it kind of institution by institution or locality by locality, rather than approaching this in all aspects of the problem. And we really need to solve the testing problem, solve the inequality problem, solve the isolation and quarantine problem, and approach this through public education as well.
And that integrated approach, I'm proud to say, Adam Silver at the NBA pulled that off. And, by having that bubble. So you created your little bubble, right? Your Cornell bubble. And, but we can create a national bubble if you had a national plan and some national thoughtfulness of this whole integrated system, not only testing, contact tracing, and managing. Dr. Mina, your comments about an approach that, as you said, that could actually change this from case by case to outbreak.
Yeah, I can't agree more with what we just heard. Now, the Ivy League schools and the universities in this country are in a privileged position to have the biomedical resources, as we heard, and the money to be able to do this. And so it is not just having the strategy alone. I think that these antigen tests, these rapid antigen tests getting out into homes can be extraordinarily valuable. They can be one of the true game changers in this pandemic at the larger community level, but not if we don't ensure that the people who need to stay home because they're sick or because they're asymptomatically infected, that they can't stay home because they have to make money and go to work and pay their rent.
And I think taking what you just said probably is the frustration for both of you, including myself, that it's not that complicated. And if you have a false positive, you can confirm that with a PCR test. And if you have a false negative, at least you have one of these other tests. And you need to think of that in a population-based rather than a person-to-person. And I don't think my concern is I don't think our viewers really understand. I worry that our leadership doesn't really understand the difference and the significance of this thoughtfulness. Maybe you could react to that first, Dr. Kotlikoff, and then Dr. Mina.
As Michael Mina said, we're in a different mode here. We should be enabling all of our resources. And what we haven't been able to do is really direct all of our federal agencies to say, shift your thinking. Now we want to do population-based screening, population-based surveillance, and we're in a different mode of thinking where it's not individual liability, it's really the population that we're trying to serve. And that's something that to date we still haven't had. Although I will say that the FDA is really pushing now, as Michael knows, really trying to facilitate these point-of-care tests to be validated for over-the-counter use and individual use, which would be a great help.
Dr. Mina, your comment?
Yeah, I agree. I think there's a huge role there. But really what it comes down to is to stop thinking about all of these tests as individual medical devices and think about how they can be used in a comprehensive public health program to tether them together, and for example, and try to actually make the most of what we have. And the FDA in this context shouldn't be serving almost as a regulatory body right now. In a wartime mode, they should be serving to absolutely facilitate the development of these tests, but making sure that the tests are being developed as carefully as possible. This shouldn't just be being left to the free market to submit applications. The government and the FDA, and this should be all hands on deck to practically carry these companies across the finish line to get their products out as quickly as possible, not stepping back and treating this as sort of business as usual. Submit your application and we'll see where it goes. This should be a directly collaborative effort in the same way, to a certain extent, that we're seeing the vaccine programs getting pushed forward.
Well, Dr. Mina, you sound like a surgeon, so I'm, which I am, and the impatience, and I completely agree with you. So to close this wonderful discussion, Dr. Kotlikoff and Dr. Mina, maybe you could give us your thoughts of where you think we're going to go from here, and where do you see us in the next quarter, and what advice you can give, not just to the new administration, but to the college students and to the public in general? Would love to hear from both of you. Dr. Kotlikoff.
Well, I have heard certainly a shift towards some of the rational and obvious public health measures, mandatory mask wearing, the kinds of common sense programs, distancing that we need to depoliticize and just make part of protecting each other. I think that will help quite a bit. I really do hope, though, that some of the things that Michael and I have spoken about this evening are incorporated into a Biden administration policy, because I think that from now until, for the next 6 months, until we have, hopefully, in best case, herd immunity through vaccination, we're at enormous risk. We're seeing a tremendous expansion of the virus. I'm just concerned that we're not approaching this with the kind of rigor that we need to, and with all of the weapons at our disposal. And so that will mean the things that we've talked about this evening: point of care tests used in creative ways, lamp tests, things done at home, but also expanding our PCR capabilities, rapidly getting sensitive tests back to populations, and making our school system safe, allowing businesses to get going, and operating in a safe and effective way where we control transmission.
Thank you, Dr. Mina.
It took us 35 weeks for the virus to hit 100,000, and it will probably take only an additional 2 to 3 to get to 200,000 new cases detected in the United States each day. So I worry tremendously that we are going to just continue seeing exponential growth. We're going to see the holidays, and I think many people are going to go home for the holidays, but they are not going to be equipped with the resources like testing to make sure that it's a safe endeavor. And we're going to see a major spike occurring because of Thanksgiving, and then another major spike occurring because of Christmas. And it's hard to blame people at this point, because this is dragging on and only getting worse. And the average person in this country is tired, is exhausted, doesn't want to keep talking about coronavirus, is going broke, all sorts of problems. And I do hope that between now and the turnover of the next administration, I hope that the Trump administration will start to act. There is no more critical point than now. And frankly, the best thing we can do is to start with a national strategy today. I worry that if we don't start acting right now, we could see, frankly, 1 million cases a day by January. And that's where we're at. This is what happens when we get to exponential growth and we pay it no mind.
Well, with that, Eli, I'll turn it back to you, Dr. Kotlikoff and Dr. Mina. Thank you so much for your discussion here, and thank you for enlightening our viewers. Eli, back to you.
Thanks for having me.
Dr. Soon-Shiong, and to all three of you, thank you so much. Fascinating and sobering conversation. And thank you to all of our guests, and thank you for watching as well. That is our 8th edition of Second Opinion, our in-depth look at matters of health, science, and technology. I'm Eli Stokols in Washington. Until next time, goodbye.